Thank you, Mark. Our panel has run over time, and we're now standing between you and lunch. So I think we'll take one or two questions. Is that okay? So if anybody has any questions, please step up to the microphone. Go ahead.
Hi again, Adam Tsai from Denver. For Dr. Wolford, I learned recently, because a colleague asked me, that phentermine is apparently FDA approved for use in 16 and older. So I'm wondering have you used it in that age group, and then what do you do when they go off to college? How do you monitor them?
So I'm so glad you asked that question, because it was one of the slides I meant to add, but in the cutting to get it into 10 minutes, it fell out of the way. So phentermine is approved for use in children 16 and above, but it's very rarely used within the pediatric setting. So there are studies that have used it, and Minnesota is an area, a university that has tried it more than most, but it's not typically used at all. And the issue of children going off to college is a huge problem, both in following them up after surgery and following them up when they're on medication. But medication use in children is very, very limited. We did a survey a number of years ago with the Children's Hospital Association looking at how many of the programs that were part of that expert exchange actually used medication, and it was in the teens, very, very low.
Hello, Jim Salas from UC San Diego, and a roundtable member, and thank you, excellent presentations. I also have a question about the surgery and the reluctance, the low levels. And I'm a psychologist, so this is not my area, but I'm just wondering about what do you think are the objections? Not just simply okay, they're too young, but thinking about long-term effects. Will there be a need for resurgery? Just worried about not beyond the iron. And maybe long-term effects and ability to follow up, or limited ability to follow up.
Yeah, thank you. I assume that question's for me. Thank you for that question. My anecdotal assessment of the situation is not that objections are so much or often based on scientific issues, to your point, complications or long-term follow-up, but rather just, not to use a pun, but a gut reaction. I think, and part of this, I think, or a large part of this, I think, is our fault. We've not done a great job with messaging and getting this out. The surgeons all know about it. We all talk to each other about it. We go to ASMBS and we talk about it. And there's been some improvement since, ASMBS and TAS now have a more formal relationship. But I think we need to do a better job messaging. We're working right now through the section on obesity at the AAP to come out with a policy statement. I just think bariatric surgery needs to become part of the vernaculum that primary care providers are familiar with.
Well, thank you. A couple housekeeping items. There is a cafeteria downstairs for the audience that joined us if you're not a roundtable member. Also, during lunch, please get some activity in. The grounds are beautiful, and you can walk to the Lincoln Memorial. Please be back at 1 p.m. We'll start exactly on time. Thank you.